Finish this session with Dr. Ashwin A Kurian, who's going to talk of complex laparoscopy in the community setting, specifically laparoscopic ventral hernia repair.
Finale, Dr. Edelman and the Society, I thank you guys for giving us the opportunity to present our data. And I thank you guys for sticking around till the end to listen to our presentation. The topic is entitled Complex Laparoscopy in a Community Teaching Hospital Practice Patterns Learned from a Laparoscopic Ventral Hernia Repair Model. I'm a chief resident at Abington Memorial Hospital and I have no financial disclosures yet. The proponents of laparoscopic ventral hernia repair quote a number of advantages that are usually associated with other laparoscopic techniques, such as decreased pain, decreased wound complications, a reduced in-hospital length of stay, a quicker recovery period to daily activities, and possibly lower recurrence rates. However, a survey of surgeons that was published in the American Journal of Surgery, where 85% of the respondents described their practice as being in an academic urban hospital, showed that the vast majority of general surgeons, believe it or not, are reluctant to employ the technique due to their belief that the laparoscopic technique was equivalent to the open technique. They were worried about a risk of enterotomy, a longer length of procedure, higher costs, a lack of experience with the technique. And not surprisingly, the survey also showed that the laparoscopic ventral hernia technique was associated with centers which dealt with higher volume of ventral hernia cases, a concurrent advanced laparoscopic experience, and a completion of a laparoscopic fellowship. Abington Memorial Hospital is a non-university teaching hospital located in the northern suburbs of Philadelphia. And the aim of our study was to assess the practice patterns in a non-university teaching hospital in the use of the laparoscopic technique to repair ventral abdominal hernias. We retrospectively analyzed a database of laparoscopic ventral hernia repairs between 2001 and 2010. And patients were divided into two groups. Group 1 consisted of patients operated on by 7 surgeons without advanced laparoscopic fellowship training, and Group 2 consisted of patients operated on by 3 surgeons who completed an advanced laparoscopic fellowship. We used the usual univariate analysis, and then we did a multivariate regression analysis. Model was created to determine the independent variables that correlate with length of procedure. Length of procedure in our study was used as a surrogate for operative complexity and for the incorporation of the laparoscopic skill set needed for a laparoscopic ventral hernia repair. And this has been done by Dr. Matthews' group as well out in WashU. All p-values less than 0.05 are considered significant. This slide demonstrates the distribution of the open and laparoscopic ventral hernia repairs in the duration of our study in our institution. As you can see, the ratio is almost 1:1. This slide does not include the patients that were operated on in the day case procedure unit. The next pie chart demonstrates the distribution of patients between the two groups with a total N of 324 patients. As you can see, the vast majority of patients were in the general surgeon group with 230 patients, while the lap surgeon group had 94 patients. The next few slides show a series of bar charts depicting the statistically significant differences between the two groups on univariate analysis. As you can see, the laparoscopic surgeon group operated on older patients with a mean age of 59 years. There were also significantly greater proportion of female patients in the laparoscopic surgeon group. This next slide shows depicts the laparoscopic surgeon group operated on patients whose repairs can be considered more challenging. The first slide shows that the mean hernia mesh size, which in our study, because it was a retrospective study, was used as a surrogate for hernia size, was significantly higher in the laparoscopic surgeon group. Laparoscopic surgeon group also had a significantly greater proportion of patients with complex hernias, and these hernias were defined in our study as multiple Swiss cheese defects, either discovered preoperatively on clinical exam or as part of the intraoperative assessment. Also, the laparoscopic surgeon group had a significantly greater proportion of incisional and recurrent hernias. As would be expected, the length of procedure and the length of stay were significantly greater in the lap surgeon group. So, moving on to a multivariate regression analysis, we found 5 factors that were significantly associated with a longer length of procedure on the regression analysis. And these were mesh size or hernia size, complex hernias, incisional hernias, lysis of adhesions, and patient age. Interestingly, an advanced laparoscopic fellowship was not associated with length of procedure. This study demonstrates that general surgeons in our institutions have incorporated the technique, the principal techniques to undertake a laparoscopic ventral hernia repair. This may be an acknowledgement of, on their part, of the advantages of the laparoscopic approach for moderate-sized hernias. Surgeons with advanced laparoscopic training tend to take on larger and more complicated ventral hernias, and hernia and patient factors contribute to the complexity of laparoscopic ventral hernia repair and predict length of procedure and case complexity. Our study calls for further surveys to be undertaken to bring to fruit what is the evolving practice patterns in the management of this very common surgical pathology. I'm just going to end with this slide just to inform you guys that 1.5 billion people in the subcontinent will be watching the final of the Cricket World Cup, which is going to be tomorrow, while we discuss advanced surgery techniques. I want to thank the Society again for giving us an opportunity to present our data, and I'll take questions.
Are there any questions? I guess I just have one. Did you break down in the two groups? Were there certain surgeons who might have been doing more of these cases? I mean, one was a bigger group of 7, so was there a particular surgeon that you might have looked at who may have done 50% of those cases for all intents and purposes? I don't know.
That's a great question. And we presented the data on that one particular surgeon who contributed 150 cases among the general surgeons. And that was presented at the American Hernia Society. And the factors that came out on multivariate analysis were pretty much similar, so it just shows internal validity of the study.
Ashwin, I always like to see a nice study come from the hospital where I was born 50 years ago. I wanted to ask if there was any detection of changes in referral patterns. So, for example, did the laparoscopic trained surgeons get more complicated referrals, or was it that the other group of surgeons were simply doing those cases open?
I think the second is probably true. Yeah. But to be honest with you, over the course of my residency, I've noticed that the general surgeons have begun to start taking the complicated or so-called complex hernia repairs laparoscopically.
Terrific. Thank you.
Thank you.
And I want to thank everyone who took the time to come to this session and participate, and the presenters as well. Thank you very much.
Thank you.